maternal and neonatal morbidity and mortality. Despite the huge advances in the medical care over the past 70 years, no new methods of assisting vaginal birth has been introduced into clinical practice since the development of the Ventos in the 1950s. So in this era, we from KCOG and KCOG plan to organize this important session on assisted vaginal delivery with Odon device. It is in association with KHERS, JNMC, JGMMMC, a session which is focused on advancement in operative vaginal delivery. So we have with us hero of NHS, the speaker of the day, Professor Dr. Tim Draycott, a senior consultant of South Mid Hospital, UK. It's absolute pleasure to welcome you, sir. We are incredibly fortunate to have you, and we look forward to hear you and share your expertise and experience about this device. I now welcome the pillar of KCOG, Chief Patron of KCOG, Dr. M.G. Hiramat, who is a constant support and encouragement to all sessions we plan to conduct. We welcome you, sir. On behalf of KCOG, I also invite our patron KCOG, Dr. Nagraj. And it is today's session, we all know, an instrumental in coordinating and organizing this workshop with a smooth virtual setup of this webinar, none other than the Dean of KCOG, Dr. Bellat. We welcome you, sir. Our sincere appreciation and welcome to our President KCOG, Dr. Bharti Rajshekhar, and Secretary, Dr. Rajashri Paladi, ma'am. We welcome you. A pleasure to welcome our Professor and HOD of JNMC Belgavi, Dr. Yashita Pujar, who's also been a support to us. Special welcome to our past President, Dr. Vidya Thobi, our President-elect, Dr. Durga Das. And also we recognize now, I think Dr. Preeti Kumar was there and she'll log in. And a special welcome to you also, ma'am. And all the other EC members and the participants, we request everyone to take full advantage of this opportunity by actively participating in this session and prepare questions which we will be taking at the end of the session. And please stay tuned till the end of the session and get answers for the same. So without further ado, I request Chief Patron and Founder Secretary of KCOG, Professor Dr. M.G. Hiramat, to welcome the address.
Namaste. Good evening. Respected Chief Guest of today's scientific program, Dr. Tim Draycott, our KCOG Dean, Professor Dr. Bellat, and all the delegates and dignitaries. It's a great pleasure for me to welcome once again our chief guest, Dr. Tim Draycott. Sir, we were waiting for this day for a long time. And this year, Dr. Bellat has become the dean, a very dynamic academician. He had promised me that he will get a overseas faculty. Within 3 months, he has arranged your program. First of all, I would like to thank Dr. Bellat. And aptly, he has selected a topic, assisted vaginal delivery with Odon device. Sir, you know that since the hood has come, deliveries are occurring. But documented deliveries, documented procedures, documented complications are there only in the last 500 years. But in 1600, the Peter Chamberlain made an attempt to deliver by assisting, and they kept this technique such a secret for a century. And over a period of time, everybody found that it has got so many complications. Then came the ventouse delivery. And both had got its own advantage, disadvantage. But now we are waiting for your Odon device, whether it is going to be the prime way of delivering. Sir, by definition, by in the Latin, obstetrics means stand by the delivery mother. Now I want to know whether just standing by her, by the side of her, are we going to help her? I don't think we are going to help her. And what has happened over a period of the evolution is that we have converted from four-leg to two-leg animals, and we have changed our posture to the erect posture, and the configuration of the pelvis has become more complicated. Now I feel nobody can deliver without assisting. Assisted delivery should be the rule of the law to reduce the maternal mortality, to reduce the fetal mortality, to reduce the morbidity, and also. And I am in the 45 years in the field of obstetrics. First 15 years, my teachers, great teachers were there who were using forceps. They were successfully using. And equally, there were so many complications. Then during my 15 years, we started using both cesarean section and forceps. Now in the last 15 years, assisted deliveries have gone to such a low, and all deliveries mean cesarean. 60 to 70% have become cesarean. Is it right? Whether we should continue this or we should. I remember that UK is the pioneers. UK obstetricians are the pioneers for the delivery, safe delivery of the woman. I think your device, which you have done, and Bella has told me that such a wonderful device which can make a lot of difference. We are all waiting to listen to you, sir. So I once again welcome you on behalf of whole KCOG and KCOG. We are 3,000 obstetricians in the state of Karnataka, and we are all listening to you, sir. It's a pleasure to welcome you once again, sir. Thank you.
Namaste.
Yes.
Thank you very much.
Thank
Sonia,
you very
sorry.
much, sir.
Yep, carry on.
May I now request Dean of KCOG, Professor Dr. Bellar, a key figure in organizing today's session, to introduce our esteemed international speaker.
Very good evening to one and all. I was impressed at the love at first sight. That is when I learned and saw him demonstrating at Wisdom Conference in Kolkata. I thought that he should come to our academic event. And this is a beginning, Tim, and we want you to see that you come more often than what we expect. So I just want to introduce briefly. His biodata runs in pages. Awards are many, many. So I just want to say that Tim Dreckott is excellent trainer. So by trainer, he got many, many awards in the training of these skills and through drills. He was awarded from the NHS, BJOG, as well as the NICE, as well as he was a recipient of the Queen's Award. And he was also awarded as the Hospital Doctor of the Year for his intrapartum emergencies work. He's such a dedicated personality we are having today, and the woman care what he is providing. I feel that we bow our head to you, Tim, and I'm really happy that you agreed. I was little behind him to have for this webinar, and he finally said, I am going to be there on 17th. And as per his convenient date and time, though he is in India, he has agreed to be with us today. Tim, I heartily welcome to you, and I request you to proceed with your presentation.
So firstly, thank you everyone for such lovely introductions, and namaste from me as well. Absolutely delighted to be here, and sorry I can't be in Karnataka and Bangalore in particular. But let me show, as just as Dr. Bella just said, what I think could be something that may change care. Oh, where's my talk? I had it just a few seconds ago. Where is it? Where is it? Where is it? Here. Yeah, so I've gone mad. Okay. So can you see that?
Yes.
Yes, sir.
So assisted vaginal birth in 21st century. So you're all probably very young people and don't remember forceps. Dr. Hiramat's just been telling me that he definitely remembers forceps. But I'm going to try and persuade you today that I think assisted vaginal birth does have a very important place in the 21st century. I'm not sure I agree that all births need to be assisted, but I think there are definitely some births that absolutely need to be assisted. Now, I'm in India at the moment as the RCOG Sims Black professor this year. And so I let me just quickly tell you. So Sir Arthur Sims was born in the UK, emigrated to New Zealand, played cricket, interestingly, for both New Zealand and Australia. I don't think you'd be doing that today. He was then knighted for his services, and he set up these 30 Sims Commonwealth travelling professorships in 1946, but only at the Royal College of Surgeons and the Royal College of Physicians. And it was his daughter, Mrs. Margaret Black, who was conferred with an honorary fellowship of the RCOG. And can you see, hilariously, Sir Arthur Sims says his wife and daughter made his life miserable, and his wife gave him hell for not having a women's health traveling fellowship professorship. And so his daughter and wife established the Sims Black professorship, which is what's covering my course in India at the moment. So we're very delighted. We should thank them for that. And this picture is Dame Hilda Lloyd, the first female president of the RCOG, Leslie Regan the second, and Rani Thakkar, as you all know, is the current third. So I was just saying as I came out that when I left London, this is London, the day I left, got on a plane to come to India, it was 5 degrees. 5 degrees centigrade. I get off the plane in Chennai, it's 35 degrees. It's 30 degrees warmer in every single way. It definitely seems nicer. And I always say about the UK that the weather is cold and grey and the people are cold and grey. I mean, if you come to India, everything is beautiful, the colors are beautiful, everything looks lovely. And I always make the joke that no one leaves Bangalore to eat in London. There's no question about that. And this is Bristol, in fact, at the same time, which is now. So I live in Bristol, which is in the very southwest of the UK. This is the part of Bristol I live in. My house is just here, and our house was built in 1760, so quite a long time ago. And it's a very beautiful part of Bristol. Now, this is my road. It is not my house. So this is to show you. I don't think in Karnataka there's too much snow in the winter. I don't think so. Karnataka is too warm for that, I think. Yeah. Dr. Bella's nodding. There's no snow in Karnataka.
No.
So, but this is Bristol last January. It's extremely snowy. It looks very beautiful, but that's not my house. I always say that academic obstetricians, I don't do any private work. They don't live in castles in the UK. That's IVF doctors. I always make the joke. So this is our hospital. We're about 6,200 births a year, so quite a big service. It's all NHS, all government. There's no real private obstetrics outside London, really, in the UK. There's about 250 midwives, 22 residents, 14 consultants. The cesarean rate is definitely increasing, let me say that. And 38% seems very high to all of us at the moment. And we're thinking, is that the right rate? Where should we be? And we have about a 12% instrumental rate. And that's been pretty stable for a long time now. The induction rate is definitely going up. And we, as our service, we look after all the pregnancies that need to be delivered under 26 weeks, and all the placenta accretors in the region, the whole region. So let me just say, let me talk about what I think it would be useful. And number one, Dr. Hiramat, said right at the outset, should we have assisted vaginal birth at all? Well, yeah, that's a question we need to answer. And I'm going to try and persuade you the answer is yes. I think we have to think about, okay, how are we going to increase assisted vaginal birth rates to the right level, not for everyone, but to those women who and babies are going to benefit from that. And how can we, what interventions can we use? And I'm going to talk about the Odon device, and here's one here. I think the only person in Karnataka to actually have a go of one is Dr. Bella. So we can talk about that as we go. So, okay, one of the things I think we've really got to be clear about in modern obstetrics is that, okay, when you get to the second stage of labor and the birth has to be expedited, there's no simple, easy, best way forward. There's no simple option in the second stage of labor. A cesarean is difficult, an instrumental can be difficult. And we have to have a think about what's the best thing. And that's where clinical experience, where examination, all those things come in. And but what is absolutely clear, that if you get to the second stage of labor and the birth needs to be expedited, then no question, a single instrument application is safer for the mother and baby than a cesarean. So if you have a cesarean in the second stage of labor, you increase the risk of PPH and you increase the risk of postnatal length of stay. You increase the risk of the baby going to NICU, and there's no question that a single instrument application is the quickest way of delivering the baby and the safest in the second stage of labor. And I think one of the things we have to recognize is that cesarean section is not completely safe. And the idea that cesarean section is good for everyone is just not the case. And if you look at the RCG patient information leaflet published in 2015, it's very clear that there are similar risks for mothers. And indeed, if you look at the term breach study 2 years afterwards, look at the mothers had a vaginal birth, mothers had a cesarean, they're almost identical. But of course, the key issue with cesarean section is what happens in your next pregnancy, your next birth. And, we all know that you're more likely to have a scalp rupture, there's more likely to have, organ injury. The risk of placenta accreta is much higher after one cesarean, much higher again after two cesareans. And I think if you think back to, when I was doing my exam in 1995, you learned about placenta accreta just for the exam because it didn't actually exist. Whereas now, we have a whole service just for placenta accreta for the region. And I think we also have to recognize, for reasons we don't really understand, but the risk of stillbirth is higher after you've had in the pregnancy after a cesarean. It's 4 in 1,000 versus 2 in 1,000 if you haven't had a cesarean. We have to recognize that there's an increased risk of childhood obesity with a section. You're more likely to be obese if you've had a cesarean. And this is a real issue we're seeing all the time now in the UK, becoming a really big issue. Impacted fetal head at cesarean section, where the head gets impacted and then becomes difficult to deliver the baby. Now, one of the things Dr. Bellard and I talked about when we met in Kolkata was, okay, in India, Padwadhan's technique is very well established. People are very confident doing it. That is not the case in the UK. So is there an opportunity for Indian obstetricians, and in fact, Manju in Mumbai has provided a video for me, to teach the world how to manage this better. But however, these red dots under there are skull fractures caused at impacted fetal head at cesarean section. It is not easy. And finally, if you have a cesarean at full cervical dilatation, you more than double your chance of having a baby less than 32 weeks in your next pregnancy. And that's probably because you're cutting through the cervix as it gets drawn up into the lower segment. And you increase the risk of perinatal death after a section in the second stage. So section is not without consequence, it's not without clinical consequence. But let's ask women what they think. What would women prefer? And what's absolutely clear is that if you ask women say, okay, emergency cesarean section is rated lowest by women. And they would prefer to have an assisted vaginal birth rather than an emergency cesarean section. And that's in high and middle income settings. If you look at lower income settings like Uganda, for example, then it's absolutely clear again that women themselves prefer assisted vaginal birth to second stage cesarean section. So I hope I persuaded you that operative vaginal birth can improve outcomes for mothers and babies. However, I think, as we all know, its safe use requires accurate clinical assessment, skilled use of instruments, anticipation of potential complications, and good communication. And I think that, yeah, we also have to recognize women prefer assisted vaginal birth to emergency cesarean section. And when we did the Odon stuff, what was absolutely clear again is that women wanted a safer, kinder alternative for assisted vaginal birth. And if we do increase assisted vaginal birth rates, so this is a study from Mozambique, Uganda, and Tanzania, where they increased the instrumental rate from 0.5% to 2%, and that reduced maternal mortality. Now, 2% instrumental rate is still very low, but it reduced maternal mortality by 11%, reduced the stillbirth rate by up to 1/4, and reduced overall perinatal mortality by 8%. So there are significant improvements, by doing instrumental births. Now, what are the issues? Well, there definitely has been a lack of training, and a lack of training for the skills of decision making in the second stage, not just the technique of instruments. And there's been a lack of training for different instruments, forceps or vacuum. And in many places in the world, there just are not the forceps or vacuum with which you could expedite the birth. And there are also issues with local practice. So if you look at Anna Pilar's work, Anna Pilar-Bertrand from WHO, she had then had a look at it and said, okay, so if assisted vaginal birth is a good thing, it's declining in numbers for all the reasons I've just said. What can we do to improve that, to give women the right choices? And she's identified hands-on, on-site supervision, training, retraining of new staff, and also future research to include women's perceptions and their views. And let me just show you here some data from the US demonstrating that at least 13 forceps are required in your whole 4 years of training in US residencies to then use them in independent practice going forward. Now, 13 doesn't seem very many to me in 4 years, but of course, the lower the instrumental rate, the more difficult it is to get experience of it too. So here in the UK, we developed the Robust course, which was about assisted vaginal birth training, and this is now mandated for training in the UK. So, I think your first and second year of training, you have to do the course for non-rotational births, and I think in the third year curriculum, rotational births are, I think, and it comes with a manual, some videos, and also a very clear simulation program. Now, just one thing quickly before I get on to innovation is, I think one thing is absolutely clear, that at all births, there should be manual perineal protection. So protection of the perineum, and also slowing of the baby's head as it's delivered. Now, these are data from Norway that have been published very recently, this year, in fact. And can you see, for nulliparous women, you definitely should think about an episiotomy at assisted vaginal birth. So can you see forceps without episiotomy, Von-2s without episiotomy, and can you see, actually here is forceps with episiotomy, and here's vacuum with episiotomy. So if you do a forceps with an episiotomy, the third degree tear rate is lower than vacuum without. So just as Dr. Hiramat said, the Chamberlains, 400 forceps are 400 years old. And he's absolutely right. They kept it a secret in the family for 100 years. We think by having a cloak, which they kept one blade of each forceps in pockets, internal pockets of the cloak, put the cloak over the woman, did the forceps, put them back in the pockets, put the cloak down, and then kept it a secret for, 100 years. And as Sophia just said, vacuum, is at least 100 years old. And when we asked women what they thought about instrumentals, they said almost all women said they wanted a safer, kinder alternative to forceps. And maybe the Odon assist device might provide that option for women. And let me discuss that. So this is the Odon device. I will show you the an animation of it. So can you see? I'll just talk you through it. So you place the device over the baby's head. The introducer, can you see? You push it down to 0, and then that ensures the air cuff sits below the maxilla and does not go past the chin. You then inflate the air cuff, which they've just done, and remove the actual applicator. So there's a kind of plastic bag around the baby with this air cuff, and then deliver the baby in a J shape, exactly like you normally would with a ventouse or forceps. Now, notice that the application of the Odon device is exactly the same for OT, OA, and OP. Now, this is Jorge Odon, the Argentinian car mechanic who invented it, and the Odon device was blessed by the Pope, which is good, and that's, I'm sure, very good. But it's difficult to see in the evidence hierarchy where that sits. So let's do some research as well as that. And we actually did nearly 3,000 simulations to try and understand how reliably this device was placed. Did it sit in the same place for OA, OT, and OPs? What fetal stations? How much pressure should we inflate the cuff to? Does it pop off if you pull too hard? And yet, how should we physically use it? And these are some of the data. I want you to bear these in mind. So can you see this? This is a heat map of forceps. And can you persuade yourself that is like a curve of forceps? And this bit here, anyone who's done a lot of forceps, you get a little indentation here sometimes when you do the forceps. And I think that's this bit here. That's this bit here. But can you see the Odon device? Because you inflate a cuff and that distributes the pressure over a wider area, you don't get so much point pressure. Do you see what I mean? Now, that I think is going to explain the neonatal benefits of this, and I'll talk about those a bit later on. Now, in Argentina, they tested a very early iteration of this device, and they enrolled 49 women. It was a successful insertion. 71% delivered, okay. But there was a very worrying 11% cervical tear rate. And that, I think, probably was because it was much longer than it is today. And also the introducers were metal. So we did 2 studies, Assist 1 and Assist 2 in Bristol. Assist 1 was very carefully governed by the Research Ethics Committee. Only 2 consultants were allowed to do the deliveries, myself and Joe Crofts, one of the other consultants. And we interviewed every single woman and every single obstetrician, success or not, after every single birth. And then we moved on to Assist 2. Now, Assist 1,
I'm squeezing the
there was only a 48% success rate. And this was at least partly because some devices, there was a kind of air leak and it wasn't perfect. Some of them, the deflation button was pressed by accident. But others, it took us, for example, 6 or 7, I have to ask Joe now, 6 or 7 attempts to work out. You have to put the device on during a contraction. So it's completely different to ventouse and forceps, which are, of course, you put on not during a contraction. We improved the device, made a number of improvements to the device. We then moved on to Assist 2, as I said. And this was powered for non-inferiority and also futility. With a new option, it's really important that to find out, okay, does it work? Or if it doesn't work, at what point should you stop? Because it's never going to work. So these are really important statistical tests. Now, okay, I'll just show you, the overall results. These data have been published in the American Journal, but there was a 74% recruitment. Now, I think that's extraordinary. That 74% of women would consent to be in a trial of a new device to be used in an emergency that hadn't been used previously. And I think it represents an incredible altruism and support for intrapartum research that, sometimes I think we're just as paternalistic about research as we are about care. And we should be working with women to co-develop solutions going forward. Now, can you see 74% recruitment, 66% success rate? So remember, it's 48% the first time, now 66%. No serious maternal side effects by our definition. A slightly high third-degree perineal tear rate, which we were concerned about, but no serious neonatal side effects. The shorter the second stage, and the lower the baby, the more OA it is, the more likely it is to be successful, but that's all instrumentals exactly the same. For those births that we couldn't deliver, in fact, most of them we just delivered with the forceps immediately afterwards. And in fact, only one of the 104 cases required an emergency section. But the big benefit of the Odon device appears to be for the baby. So there was a very low APGAR, and the most interesting thing was there's not a single mark on a baby. There's not a mark on the baby's face, because remember I showed you that graph, that heat map, where the pressure is distributed, so you don't get a chignon like you do for a ventouse. You don't get a blade mark from a forceps. And interestingly, the pain scores for babies were much better than either forceps or vacuum compared to an Odon. And the Odon pain scores for babies were actually extremely similar to normal unassisted vaginal births. So there's less marks on the baby's face. There's no bruising more than 5 centimeters. And of course, every ventouse has a bruise more than 5 centimeters. And day one feeding was better for infants delivered by Odon, we think, because they were in less pain. And women were extraordinarily positive about this. So women said, I was against forceps, and women said, look, it's a really positive experience. Now, is that, it could be the Odon, but it also could be being part of a research trial where research midwives look after you, they contribute to your care along with our core midwives. But even mothers-in-law wrote in to us afterwards to tell us they thought it was the best way of delivering a baby. Now, I'm not sure how many births they'd seen, but they were very positive. Midwives are also extremely positive. And everyone seemed to agree it seemed gentler than forceps or vacuum. Now, then we moved the trial to do another 104 births in Besançon in France. Again, extremely impressive recruitment rates above 70%. But can you see their success rate was now 88%? So we've gone from 48% to 66% to 88%. So we're getting better over time. And there were, I think, 2 reasons for this. One is France is slightly different care. They would offer to expedite the birth after 20 minutes. But also we knew a lot more about using the device in this 104 because we'd already done a lot in Bristol. They had half our third-degree tear rate, and I think that's important, and we need to understand that a bit better. And again, huge benefits for the baby itself. Now, we published these data in all 3 of those studies in the American Journal, and we've also published women's experiences of the device. We've got a training program now. The Odon Assist is what the device is called, and we have a training program including videos for people to use. So let me just summarize what I think the key findings are. And okay, it is feasible and safe to recruit to studies of the Odon assist device and intrapartum research. Okay, we met the threshold to continue Odon assist research, and can you see there's a progression, 48%, 66% to 88.5%. And I think that's with we've improved the device, we've improved the technique, we know more about it now. We've altered the clinical parameters for use because we've actually stopped doing it at 0, which doesn't seem to be very effective, but +1 and below does seem to all be effective. And the operator learning curve seems to be about 5 births. You need to do about 5 births with it to get good at it. The other potential benefits, as I said, there's a huge reduction in neonatal soft tissue trauma. I mean, an enormous reduction. And I think that's what makes it so potentially interesting, and particularly for women. And think about Von-2's forceps clearly can leave marks on the baby, but think about Von-2's. I don't know if anyone's tried to put a Von-2's in their hand, but it can be extremely uncomfortable after 5 minutes or so. Women want a safer, kinder alternative to the existing options, and maybe the Odon device is that safer, kinder alternative. One woman complained that the birth was very, very uncomfortable, and then it turned out she was actually talking about the urinary catheterization was much more uncomfortable than the birth itself. But I think there might also be benefits for obstetricians in that the actual technique, the placement of the device, is very similar for all fetal positions. So it's not like a Kiwi or a Von-2's where you have to get it over the flexion point. I think we can be much less Catholic about that. But I think there's more to understand. I'm going to come back to this in a second. There is a randomized trial in France about to start. There are feasibility studies in Italy, Rome, and Parma. UK centres are thinking about it too, Barts in particular. But we are very interested in the potential to do some of this work in India. And I know Jaideep Tank, the president of FOGSI, has been very successful securing some funding to do some work with the Odon device in Indian settings, so that excellent Indian obstetricians can contribute to the knowledge about how to use this device. And I'm very, very keen on that. Can we do broader monitor implementation? I'm sure we can. I do think we need to do a bit of vaginal research. And if I was with you, I would definitely do a demonstration, but sadly I'm not. Now, I did do a demonstration in Coimbatore and Chennai with both senior and junior doctors, and everyone was very, very taken by it. So I will just say thank you very much to our late Queen, who sadly has passed away. But we were very proud to win the Queen's Anniversary Prize in 2014, just as Dr. Hiramat said and Dr. Bellard said, for our work in training. And this is the Queen presenting me with the award. My mother was delighted, except when she saw this photo, because she didn't really like it that my hands are in my pockets. She thought that was slightly casual to talk to the Queen. But we are very proud to include this crown on our work forever, to celebrate the Queen recognizing our work. So we're very grateful to her for that. Thank you. So let me just summarize. I think assisted vaginal birth definitely has a place in current maternity care. Okay, women prefer it to emergency section, and there are very definite clinical benefits of assisted vaginal birth for both mother and baby. I think we have to think about how do we provide proper information for assisted vaginal birth, how do we provide training and support for assisted vaginal birth, particularly the decision making around assisted vaginal birth in the second stage of labor, and how do we continue to innovate in assisted vaginal birth so that we can bring the benefits of assisted vaginal birth more broadly across the world. So thank you very much. I'm very proud to have presented to this esteemed society, and I promise I'll try and get to Bangalore at some point, at some stage. I can't promise when, but I'll definitely do my very best. So I'm very proud to have presented to you all. And if you had any questions, that's my email there. That is the new RCOG. And if anyone is a member or fellow of the RCOG, then that is the new college. We'd love to see you there at some point in the future. So thank you. I'm going to stop sharing my screen. And if you had any questions, I'll be delighted.
Thank you, sir. Will you take some questions, sir?
Now, before
Delighted.
that, MG, some people want to see that animated video again. Can you just go back and show?
No, the question is the same. The question what I am going to ask is, number one, what is the material used for this device?
Yeah.
And whether this device needs to be sterilized, and what is the cost of the device? And third important question, what I would like to know is that when you applied that device, you have gone right up to the chin. The problem in all deliveries is it is at the level of the biparatal diameter. How can you pass this device beyond the biparatal diameter? That is what we want to know.
Yeah. So those are all great questions. And okay, so let me start off. Okay, it is not available to buy at the moment. And I think that more work needs to be done in a research setting so we can understand it better before everyone just starts using it. But if you, I think Dr. Bellard has the contact, the Indian leader of the company. It's a not-for-profit company. It's an American charity who are making these. And his name is Manoj Gopal Krishna. And he will be at the meeting in Kolkata. But I think, Dr. Bellard, you have his contact details.
Yes, I do have.
If anyone wants to contact him, he'd be delighted to talk to you, I'm sure. But let me just show you quickly. Okay, so it's a plastic bag. It literally is plastic. Okay, can you see it? And you've got a pump. And this here is not a vacuum at all. It's just to spread the applicator over the baby's head. Yeah. So to your point, Dr. Hiramat, that's a great question. Okay, so let's say this is a baby's head. Okay, you push it over the baby's head. You push it past the widest diameter. You're absolutely right. But you need to lubricate it inside and outside. You push it past. And can you see when you get to 0, that green 0, can you see that?
Yeah.
Yes, sir.
Yeah.
Okay, if you get to 0, you cannot go past the maxilla. And then what happens, exactly as you said, once you've gone past the widest diameter, why doesn't it just come off? Well, what happens is you then inflate the cuff. So that's the introducer. I've just taken it out. So can you see if when I pump it up, have a look. Can you see the cuff pumping up like that? Yeah.
Yes.
So can you see that then narrows the diameter, which is why it gets stuck here and around the occiput. And I think, and I would show it to you if I had a model here. When you inflate the cuff, it pulls the chin in. And I think it works by flexion.
Yes.
Which is actually how Ventouse works, doesn't it? It works by flexion. You're flexing the baby's head. And in fact, all of intrapartum care is about improving the flexion of the baby's head, isn't it? You know, let's face it. So, and then can you see, and then let's say, but you can't, let's say you're delivering the baby's head. Now, okay, I know you know this is not a baby's head, but okay. So you deliver it like a J shape. Now, interestingly, in France, in the UK, we use the handles like a shopping bag, which it's not very glamorous. It doesn't seem very medical, but now in France, when they did it, they spread the handles like this. And I think there's something that actually it comes down slightly better with the handles slightly spread. Do you see what I mean? You can kind of shuffle it down a tiny bit. But the actual technique is exactly the same. So descent around the corner and up is born by extension, exactly the same. Now, it's really, really important to deflate the cuff before it comes through the perineum. Because, of course, the cuff is making the baby's head wider here. So as soon as it comes down, and as soon as you can feel the head distending the perineum, then you can deflate the cuff and protect the perineum and bring the cuff off by deflating it. Do you see what I mean? Now, but we've only done 250 in the world. There's only 250 in the world. Now, 250 in India is 20 minutes work. This is, you're laughing at me because you've just done 250. You don't come back when you've done 2050. Come back and tell me when you've done some. But this is where I think if we could get the best of the UK and the best of India working together, so we say, okay, we help you with systems and structures of research, and you contribute the volume of work and your expertise, then I think that would be a total success. And as I said, Jaideep Tank, the current president of FOLSI, has got funding from Gates to do this in some units. So I when I first saw it, let me be honest with you all. When I first saw it, I thought, absolutely no way. This is madness. This is absolute madness. But now, I think it might replace Ventouse. I think there are advantages for mothers, advantages for babies, and advantages for obstetricians. And that is a very rare combination in my experience.
I like your word safer and kinder. Your statement safer and kinder.
Yeah, a safer, kinder alternative. You're absolutely right. I think that's really important. So let me have a quick look at the chat and see what people said. Do you use intrapartum ultrasound? Okay, that's Shanta asked that question.
Yes.
I actually don't, because I'm extremely old. If you're young, you do use it. Shanta, you look very young to me. So I'm 60 and don't use it. All my juniors use ultrasound, and I think we should know the position of the baby before we do anything. Okay. Secondly, the bit I am convinced about ultrasound, and I'm not convinced about most of it, but the bit I am convinced about is the head perineum distance, which is the same as station, really. If the head perineum distance is more than 4 centimeters, instrumental burst is less likely to be effective. But we didn't use that for this study. But again, that would be a great bit to include if we did this work in India. Do you see, with excellent Indian sonographers? I said I'm going the wrong way around, I think. Good evening. Shoba says residency training very good. Yeah, you're absolutely right. Couldn't agree more. Ambrish says innovative and interesting. Thank you. That's lovely. Shanta. Oh, another question from Shanta. What's the technique of extraction in occipital posterior position? That's a great question. For OT, it rotates spontaneously to OA with the flexion, like auto rotation, like a Ventouse. But OP comes out direct OP. Now, I think anyone who's done a direct OP, it has to come out slightly further before it comes up, doesn't it? Because you're flexing on the chin, not the occiput. So I think there probably is a different technique. So let's see. Bharati, I'm okay. I'm going to apologize for my terrible Hindi. Okay, and my murdering all your names. I can only apologize. Bharati, Odon looks promising. Thank you. Shanta, wow, you're on this. You're right across this. You want the video again? We'll talk about that. Yeah. Dr. Hirmat's done the questions. Can we get trained to use the device? That's Muralida Rao. I think yes, but in a research setting. But I think you need to nag JD Tank. He's making the decisions, not me. JD has got some funding. He's making the decisions. He's going to decide where this gets in. But I will help with training and how to use it. Vidya, thank you very much for lovely words. Prerequisites for application. Yeah, that's a great one. That's I edited Jane. I don't think that's the name. So the prerequisite for application, exactly the same as a Von-2s. So naught fist palpable abdominally, +1 and below, all fetal positions, and you think it's going to be delivered vaginally, you know, the same. Bharati says, is the device reusable? Okay, I'm going to say it's a single-use device. Let me say that. However, I don't know if any of you have worked in other parts of the world where you see a kiwi with a sponge taken out and hanging up to dry on the drying line. That clearly is not. That's kiwi is not meant to be reusable either. So let's see, but we can talk about that. Shoba OP, we've talked about that. Mention not for human use. That's very wow. Okay, you've got whoever that is. Sameshwar, you must have fantastic vision. You have got the best eyes in the world. That's absolutely true. That's to stop people. That's to stop people. And just there was a chap in a meeting we went to, and I was there with Manoj, and a chap. He was from a different country, I think possibly China, and he said he looked at it. He said, "Oh, can I have a free sample?" And he just took one and left. We said, no, they're not ready. You can't use them. He said, I'm going to make my own. I said, okay, no. So they now put not for human use, but clearly they're not for delivering puppies or calves, or, you know, they are for human use. It's to stop people using them. Swarapa, thank you very much. Okay, Vidya. Okay, a really good question. Hop off alternative methods. Okay, that's a great question. It's a bit like a Von-2s in that, you know, if you do a Von-2s and you just pull it straight away, it pops off, doesn't it? So the thing about a Von-2s is you've got to get up to the maximum pull slowly. So slowly exert the traction to get up to a firm, and it's exactly the same with this. As I presented in the data, for us, the vast majority, in fact, everyone apart from one, was delivered by another instrument. Now, in the UK, we would routinely use forceps if a vacuum has failed. So most of them were forceps, but I think you would use whatever you're most comfortable with, I think. Shanta, yes, lovely. Sonia said patient-friendly, fetus-friendly, fetus position-friendly, yeah. Do you dictate the direction of pull, the number of pulls in the device? Okay, so wow, this is a great audience asking me top questions. Okay. At the moment, okay, there are two answers to that. The first answer is that we do the same 3 pulls as you would a forceps or a vacuum. Okay, that's the simple answer, I think. However, this is where I think we need to do more of these device deliveries, because in an ideal world, I would sit down with obstetricians from Italy, the team from France who are doing the randomized trial in the UK, India, lots of excellent Indian obstetricians, and we'd all meet up after we'd done another 100 each, and we'd say, okay, when you did it, how did exactly you define and refine the technique? Because I think this is exactly kind of what we need to do next. So I think there are 2 answers, 3 pulls, but we need to know more about it. Shoba, when the episiotomy given, yeah, okay, selective episiotomy, that's a great question. In nulliparous women, the evidence from forceps and vacuum is that episiotomy is useful. We're less certain about this one, but it probably is going to be the same. It's probably going to be the same. Rajashri, any contraindications? The same contraindications as any vaginal birth, you know, any instrumental. Yeah, exactly as you say. So, you know, if it's high, if you don't think it's going to come, you know, all those things. But I think I think is informed consent, Sonia, needed? Yeah, 100. Yeah, I mean, but again, informed consent is a very, very interesting issue, isn't it? Because are we really getting informed consent in an emergency? You know, I think it's kind of ceremonial. But Dr. Smita is sharing her screen.
Okay. Mr. Arun?
Sir,
Yes, sir.
Okay, that's lovely.
vaginal delivery is safer for the patient. Cesarean delivery is safer for the surgeon. Do you agree with this statement?
Well, yes and no. Because it might be, it's not safer for the, yeah, you're right. That's a funny joke, and I like it. I like it. I see what you're saying.
Because medical legal issues are one which are dictating us for the mode of delivery.
You're going to be sued when a baby has a preterm baby next time.
Yeah, we are all worried about medical legal, and
Yeah,
many times we err for the cesarean.
Okay, I'm the head of all maternity litigation in England. I'm the head obstetrician for all maternity litigation in England. So I know a lot about maternity litigation, I'll tell you. And it's very, very expensive in England. But, okay, a cesarean does not always protect the doctor. Let me say that. But again, you know, we've got to be careful. Okay, any cervical lacerations, Dr. Bellard, top question. And I'm sorry I didn't answer it properly. You're absolutely right. Remember I said it was 11% cervical tear rate when they first started using it. Well, that seems really high to me. I haven't seen a bad cervical tear for a long, long time. With the Odon, the new device design, we didn't see any, Dr. Ballard. No cervical tears at all. But yeah, that's a great question because I needed to say that. And Shrupa, do I agree with it? Yeah, I definitely agree. It's a good thing to do. I mean, well, what I agree is that we need to do more research and we need to do it quickly in high volume units so that women can benefit from this if it's useful.
Yeah.
And I think obstetricians will benefit from this. I actually think that, you know, it's the same application. I actually think there are benefits to it's just, Sonia, as you said, it's fetus friendly, obstetrician friendly, mother friendly. Is it wallet friendly? I don't know. Ask Manoj. That's, you know, is it price friendly? I don't know. But for women, obstetricians and babies, I think it's definitely useful. Shoulder dystocia.
Comment on the residency program.
The same incidence as everyone else, but shoulder dystocia is a different technique. I mean, in the UK now, okay, we haven't had a permanent brachial plexus injury in our service for more than 70,000 consecutive vaginal births. Okay, if you train people properly for shoulder dystocia, and there are data from the States, from Finland, from Sweden, from Spain, from Germany, from New Zealand, showing if you train people properly for shoulder dystocia, you can eliminate permanent brachial plexus injuries. Pretty much.
Sir, what about the residency program? Is it the need of the hour to plan in a different way?
So this work was all done by Emily Houghton, who was one of my research fellows, who is one of our residents. So, but I don't think we can introduce it into a residency program until we know more about it. This is for experienced obstetricians to use to define the technique. So I want, Dr. Bellard to do a few and say, well, Tim, actually, when I do it, I go straight to a 4 and I drop the handle down, go up. You know, is it different for OP? Is it? Yeah, I don't know. There are some really important subtleties that we need to do more with.
I agree. Yeah, I really agree with you, Tim. And another important thing is it needs really some more trials in different regions and with a genetic background. But what we have noticed, the perennial context in the Asian women and the European and US women, the elasticity is different because our women tend to have more lacerations, especially perennial lacerations, than the European or in the US women. I don't know about your comment, because you have the Indian people in USA, I mean UK, who are
Yeah.
delivering. The tear probably should be seen there, because we see that more in Indian women.
Yeah, well, you say that. Yeah, okay, that's a really good point. And okay, let me just go back to the presentation for 2 seconds. Yeah.
The animation video, you would replay it again, sir?
Yeah, sure. Here we go. Yeah. Let me just quickly do Dr. Barr's question. Okay. Yeah, if you look at okay, if you look at these data, whoops, can you see that we actually had a very low Indian, it's 2% of women. So we had a very low rate of Indian women in our study. So 88% white British. Now, is that because Indian women didn't want to be recruited to the study, or actually we have a very low, number of Asian women? I don't know. But Dr. Bellard, your point is well made, that okay, we need to do this work on Indian women, for Indian women too, not on, for. The animation, let me just do that for you. Yeah, here you go. If you could see it on a model, it's actually a lot easier to see on a model. But there's a baby, that's OA clearly. So can you see, there's the applicator, you push the plastic applicator over the baby's head till 0, then it cannot go too far if it's 0. Then you inflate the cuff by pumping the air chamber on the handle, take the applicator out, and then it flexes the head, and it's pulling underneath the axilla and over the occiput. Do you see what I mean? Can you see where it is? And then deflate the chamber, deflate it as you deliver the baby through the perineum. So about 5 minutes is what we took to deliver babies. In France, it took a bit longer, actually, and I think there are things to learn from both those two things. But yeah, so let me stop sharing again. Is it one size fit? Rajshri says, is it one size fit for all? Yeah, it is at the moment. And again, but what's interesting is Indian babies are not that much smaller now than UK babies. I mean, what's the average in India? 3.2 kilos now?
No. Our
Around
average
2.8.
around 2.8 or 2.7.
2.8. 2.8 to 2.9. Yes.
Chennai, they told me it's 3.2. Maybe they're bigger in Chennai, but
It must be urban data. It must be urban data. Urban data.
I'm sure,
Yeah.
I'm sure it probably is. But
Tim,
so,
I have a question.
Yeah.
Did your women allowed for delivering women allowed the video recording of the delivery? Any one of your trial patient?
So in the UK, they would never agree to that. No one wants to be on a video of their perineum on YouTube. That the UK women, we get undressed in a dark room in front of your wife, let alone anyone else. We're very, very cautious in the UK. In France, they did do some videos, and Nicola has got some, which I haven't got permission to show you today, but yeah, there are some. So, and you can see it and kind of how it's done.
That would be nice. Probably that will help in training also, and and how to avoid complications also. Thank you.
Well, I think we need to do more work to avoid complications.
Yeah,
that's. I think there's going to be more to the technique than we know already. I'm absolutely certain there's more to know. Do I have a demo on a live patient? Yeah, and yeah, I've done loads on live patients, but yeah, I haven't got a video of them.
And in the context of this demo, so whenever you come for any workshop on this also, we need to take now special permission from our Indian Council, Medical Council, and Karnataka State Council. But when you are planning to come, definitely we do that, and we can plan a delivery with the consent from the patient.
I'll be very okay. I would definitely do it in the context of a research study.
Yes.
Okay.
I'm not
Correct.
going to do it.
It cannot be
Just
done
go
ad
to
hoc.
people.
Yes, yes.
Yeah.
You can't,
I agree,
So-
because still it is not approved for the use unless
Well,
it
it
is approved by some of
No,
the.
it is approved. It is approved.
Yeah.
No. European
Research
society still
framework.
it is not yet. It's not yet approved.
Well, we need to do it in a research framework. I think that's good for women. I think it's good for us. It's good for increasing knowledge.
Correct.
Let's see. But I think, as I said, when I first saw it, let me show you how horrible I am. I thought to myself, no Argentinian car mechanic tells me how to deliver a baby. I mean, I've delivered lots of babies, as you all have too. And then when we started using it, we thought, actually, maybe there's something in this. Yeah, there's something in this. And I think we need to know more about it. And we would love to work with you all. But you've got to ask JD, not me. JD has the cash.
That should
He's
be
a very wise man as well.
He
He's
holds,
president.
he holds the purse strings. He holds the purse strings. I just
Yeah,
wanted to,
Yeah.
just wanted to give an input here, Dr. Tim, that
Yeah.
you know what, we have always been kind of love-hate relationship with our delivery rate in India. As obstetricians, we feel it is overwhelmingly, at about 26 to 29 million births per year, is the largest in the world. But then what we have not understood is that this is a great field, great potential for creating data, very, very huge data we can acquire if we have the correct direction. So this is one of the opportunities where it is possible for us to generate data, I'm sure. And
what I'm most worried about, it'd be like cricket. So India starts research, and then you'll be telling me how to do it afterwards.
no,
It's like the cricket team.
no, I didn't understand. I didn't understand.
The Indian cricket team, we British brought cricket to India. Now you're much better at cricket than us.
That's a good one. That is undoubtedly so. But
That
I hope
is
that we are
true.
but we are perhaps more very proud of our obstetric practice, actually. So more than we are of our cricket. So we will be able to give clean data. And today I am happy to say, and I think Dr. Hiremat, Dr. Bella, everyone will agree with me that today research in India is at a different level, clinical
Very
research. And we can generate clean data. And, it is possible to have. And successive FOXI presidents also are more keen towards that. So it will be good, I think, in the coming years. We are hopeful.
But this is what I said. This is what I said. I think if we could join up the skills and the expertise of India with the skills and the expertise of England, the UK, then I think we could actually help the world improve maternity care. I think that's a real opportunity. Just like you said, that's the absolute opportunity here. And Gates, it's Gates' money, Bill Gates' money, JD's got funding from. So yeah, let's do something exciting so that India tells the world how to improve care. I mean, look at yesterday they showed me some preterm labor cases from Coimbatore, and we went through a few. They were difficult. Let me say that. And so Indian obstetricians, they've got some skills. Yeah, I don't have to tell you that. But and I think this is where we need to harness the best of India and the best of the UK. I mean, the joke in Europe is, what would be the best thing in Europe would be the British are the policemen, the Swiss run the trains, the Italians do the food. What would be the worst thing in Europe? The Italians do the police, Swiss do the food.
British.
But if we could take the best of Indian excellence and the best of UK excellence, I think there's the word you said, Shobha, is the perfect word: opportunity.
Yes.
That's what I'm going to
Yeah.
say. That's what I'm going to say in Kolkata at the AICC meeting. Exactly that point.
Dr. Bellad,
Yes, sir. I think
concluding remarks.
it was a really great meeting we had, and Tim, it was amazing presentation, and you really did a wonderful presentation and solved most of the questions which the participants had. And I think years to come, this device is going to make a big difference in the vaginal delivery. MG Hiremat, some comments, and then we'll see.
Dr. Tim,
Yep.
very, very nice and thought-provoking scientific session. And we'll definitely come in the streamline of popularizing this method, because all have taken so much of time. Probably this is at the research level, as rightly told by one of the committee member, that India is a place where you have got huge opportunity. And whenever you come here, we'll arrange workshops and we'll definitely popularize and safety of the mother in the delivery. And it is, I think, one of the most important thing. Women's health care is our priority, sir. So I once again thank you on behalf of all the KCOGians for having spared such a long time, almost about 1.5 hours. And many of our doubts we have cleared. Many of our doubts we have cleared. Probably these will be better cleared when we conduct a workshop on a woman who is delivering. I think that will be great, sir.
Yeah, MG, he has a device and the model. So probably we should invite him for our
Let me just say.
Yeah, definitely will do.
NHS is paying me to work in the NHS. As much as I would love to be in India, I would love to be in India. I cannot. So I got 3 invitations to conferences in Coimbatore yesterday. So I'm going to try my very best to please everyone.
Just one last word, sir. Your vaginal delivery has stabilized at 10 to 13%.
Yeah.
Am I right? In UK?
12% UK, yeah.
So why it is not increasing? When you say that the vaginal delivery is so safe, why your vaginal delivery rate is not increasing?
That's an interesting question. Not every vagina, but okay, our second stage cesarean rate is less than 2%.
Cesarean rate in UK,
most
how
people
much, sir?
have a section. Most people who have an intrapartum section is before the second stage. I mean, so there's not that much opportunity, and hopefully women who are completely normal don't need any help at all. That's perfect, So 12% seems to be a stable, 14% seems to be stable. The WHO says in settings without epidural. Now, I didn't discuss these data, but in our service, we have about a 40% epidural rate. In Paris, it's 95% epidural rate.
Sir, your time and again you have stressed that vaginal delivery during the second stage.
I mean, most people think that a 60% vaginal birth rate, unassisted vaginal birth rate, should be completely achievable. Now, okay, so should we have 12-14% instrument, assisted vaginal birth rate? Should we have a lower section rate than we currently do at the moment? Yes, I think there probably are some advantages to that, but we have to do the right thing for the right woman. And this comes down to clinical skill, comes down to understanding the context, understanding difficult decision making in the second stage of labor. These are not easy decisions. Now, as I said, we did a Keelan's on Monday with one of our trainees. Did it very beautifully. She did it absolutely beautifully, and that baby the mother and baby are better for having that birth. But let's just not go mad. I don't want everyone to have an assisted vaginal birth, but I think where that's the best thing for that mother and that baby, it should be an option.
Okay, Bella.
I'm sorry. I'm sorry.
Yeah.
I'm boring.
No. Absolutely fine. I think if there are no comments and wonderful session, I request Dr. Suman Gaddi to propose the vote of thanks.
Thank you, sir, for this opportunity. Good evening, all. First of all, I would like to thank today's brilliant speaker, Dr. Tim Draycott, for his excellent talk on assisted vaginal delivery on online device. Now, the key points which we understood was that assisted vaginal births have a role definitely in the 21st century, and it is a single instrument application which is safer than the cesarean section. And of course, accurate for its application, accurate clinical assessment and skill is needed. Now, as Dr. Tim mentioned, that it is a safe and kind device for both the mother and the baby. And it appears definitely for all of us a promising, innovative device. And definitely thank you, sir, for this excellent demonstration of the device. Then I thank the entire KCOG team headed by the Chief Patron, Dr. M.G. Herimat, and the Dean, Dr. M.B. Bala. I must especially thank him to have arranged today's talk on this device. Of course, all of us have learned so much about the device. And then I thank Dr. Vidya Bhatt and Dr. Sonia Mandapa for this logging in, and I thank the entire KCOG team, Chief Patron Dr. M.G. Herimat again, and Dr. Bharti Rajshekar, Secretary Dr. Rashi Paladi. I also thank the KHERS team and the Head of Department of OBG of JNMC, Dr. Yashita Pujar, for logging in. I thank all the delegates who have logged in, and also finally thank Mr. Arun for providing this Zoom platform. Thank you, one and all, and